The data earlier this year, I think on a publication in JAMA, showed that in counties with higher numbers of Black primary care physicians, that Black individuals have like a higher lifespan. Now, this is important because when you look at like a broader context, part of health disparities we have is that Black people tend to live, tend to have a shorter lifespan than whites. A lot of that, some of that's due to like the social determinants of health, and quite frankly, having, lower access to healthcare. But there also just seems to be something about, when you have a Black provider, that is resulting in better outcomes. In addition to that, when we then also point to other micro issues, one of that being the maternal outcomes in our country, a big part of why maternal outcomes are disappointing for us right now in our country is that there's a big gap, right, between, Black women and white women. And it's been shown that when Black women, have access to Black maternal providers, that the outcomes are better. So I think that's, on a macro lens, and, when we specifically look at also maternal health, it bears out the fact that, we need more diversity in our healthcare workforce.
Yeah, absolutely. And those are, like you mentioned, more macro, bigger themes. We see that having doctors who look like you, referred to as racial concordance, actually results in so many different improved outcomes. We have patients reporting better satisfaction and higher ratings of their experiences in care. We see that patients who receive vignettes, cases where they're being advised by a doctor who looks like them to have recommendations such as cardiovascular surgery or catheterization to look for a clot in their heart, and those patients are more likely to agree to those procedures if they have a doctor that looks like them. We even see lower healthcare utilization when you have racial concordance between doctors and their patients. So this matters, like the fact that we are so far from achieving racial diversity in our medical field compared to what we see in the country really suggests that this decision that was made by the Supreme Court earlier this year is, as some of my colleagues have written, is actually going one step backwards when we should be going forward. We're seeing that clearly strides have not been made, but rather than going forward and being direct and precise with addressing this specific issue of racial diversity in and medical education, as we're talking about today, but also higher education in general, we are keeping things broad. We're keeping the conversation broad. We're keeping the policies broad. And I think that's the biggest reason why affirmative action policy has been imperfect thus far. And it's consistent across the board. It's September right now. People are getting flu vaccines. People are getting new COVID vaccines. We saw the story play out in COVID when we tried to pinpoint policy to improve access to COVID treatments, improve access to vaccination for the groups that were most deprived and most disadvantaged from the pandemic, which happened to be folks from racial and ethnic minoritized backgrounds. And when those policies try to come into place, there was pushback, there were lawsuits, et cetera. So we see this in education, we see this in healthcare, and the fact that we're hoping to bring policies together to address the education system and the diversity thereof, to hopefully address the disparities that we see in healthcare, I think is why we're having this conversation today.
I think both for us to sort of fix affirmative action in terms of making it more effective, but now to move forward from it, now the Supreme Court has taken that away, I think it means that we've really got to look at our, schooling policies when going back to K to 12. We have to get to those foundations to invest equally in our students, because we know that there are gaps, even when you are matched for income. Schools that have higher percentage of Black students, right, and minority students versus schools that are predominantly white in terms of the amount of funding that they get. We also know that due to the fact that until medical schools had opened up to people of all races, that, different communities who have had family and community members around them who've had the opportunity to enter medicine, that, there are other avenues for them to get informal lines of information in terms of how you approach applications, right? In terms of getting involved in like medical research. We're proposing putting in place partnerships to help sort of close those gaps. And then when we get to sort of the medical school application period, right, and going into medical school is then thinking about, okay, can we, go and recruit people from diverse colleges and universities, not just our HBCUs, right, but other schools like the University of Maryland, Baltimore County, that has a record of having high levels of socioeconomic diversity. And kind of what stuff that the Biden admin has been doing, kind of looking at geography in terms of its links to inequality? Can we emphasize geographic diversity in terms of granting interviews?
2 points that we didn't make, I'll make, and then I'll allow Victor to expand on anything else that I missed is hopefully addressing this issue of the cost of getting into medical school. So one of the biggest drivers of cost is taking the medical college admissions test, this MCAT exam that kind of affects so many people and really discourages a lot of people from actually attending medical school, as some of my colleagues and I published earlier this year. That exam itself costs money, the prep materials cost money to take the exam. And so we are arguing that we need more early admissions systems and processes, early medical commitment programs for our students who, in their graduating from high school, they can actually get into these BA, MD programs where an MCAT is not required. And again, you can help improve the access to medical school with eliminating this very, unfortunately, disadvantaging criteria for individuals of color. And the second, and I think a really important piece that we have to make is really addressing holistic review. And so we're no longer able to use race in the admissions process as like a checkbox or criterion according to the Supreme Court, but how are we able to look at the broad journey of our future physicians as they go through this pathway, whether it's as a pre-med, as a medical student, as a resident, as we meet them in training? What has their journey been towards this field? How did they choose it? What's their background? What are some of their socioeconomic challenges or not? How has race influenced their experience in this world and potentially their decision to pursue a career in medicine? Those are going to be hard things to examine on an interview. We're in the interview season right now, and we're being asked to interview numbers of residents or resident applicants. That takes time, that takes effort, that takes people, taking people out of clinic, perhaps taking people out of their regular research job to be able to do this heavy lifting of reading essays, reading applications, et cetera. You can't just look at a score and look at a checkbox and say, come on in, come and interview. And so really investing resources in that holistic review, teaching reviewers to be anti-racist in their review and not have some of the unconscious biases that come to us, all of us, when we're reviewing applications, I think is really going to be important. And again, this is an investment that schools need to be making today, not waiting till next year to see how things shape up, not waiting till the year after this year, to be able to ensure that we're not going backwards with some of the numbers that were already so poor.
We have to think about the end target. We want a more diverse and we want a more empathetic, medical workforce that will result in a more effective medical workforce, right, in terms of patient outcomes and in terms of cost. And part of that is making sure that it's not just also like getting you to med school, right, but it's along the whole pathway, supporting all our students equally when they get there, making sure too that, when you get to residency, which is like that terminal stage of medical training, that, you are not being discriminated against. You're not being excluded on the basis of race, because those can have very negative and harmful repercussions in terms of one's ability, to get that final certification to go back to their community and serve. So I think it's making sure that, we all take responsibility in that. And a second point I think I'll make is, now that I think, affirmative action, and at least in higher education outside of the military academies, has been ruled unconstitutional, I think Chief Justice John Roberts made a point, right, that, people can still discuss their race, right, in terms of how it has affected them as individuals. So I think it also means that from a race lens, it's shifting, we're shifting, I guess, away from a paradigm of groups and I guess like a checkbox, so some could say, to then, now looking at you as an individual, right? So I think to the point Dr. Essien said, I hope that the resources are put in place and the time is taken to really, look at all our students in terms of how all aspects of their lives have shaped them, race being a part of that.